So I'm Masood. I've been a GP for 22 years, same practice where I was a trainee and a partner. I look after the practice. It's a 31,000 patient practice, about 130 staff. And just the logistics of navigating and getting people on board, plus your patients to do things, has probably taught all of us, I think, about the challenges of making transformation and change happen. About a year and a half ago, I've been doing a CCIO role in Birmingham Solihull for a long time, which is where I've worked closely with Tanya and James and John, who's on this call as well. But more recently, about 18 months ago, there was when the CCG disappeared and transitioned into ICSs, there was an opportunity to do a role where we were doing more. And actually, I think for me, I didn't want to just be known for doing just digital. I wanted us to know how we could influence other elements of it. And I've spoken about this before. All of us need to be at the table in other meetings because we have so much knowledge and expertise and experience that it's really important that we get to be at those places. We're in the group of people who aren't afraid of digital. Okay, but equally we have other skills and clinical knowledge where we can contribute in a very positive, proactive way to these meetings. And the medical director role has helped me to do that. So that's why today, normally I'd be talking digital only. I'm going to be able to talk to you about elective care, diagnostic pathways, because as medical director for integrated care, I have a responsibility to be part of those discussions, influence them, contribute them, lead them. And that's been useful. And that has taken away some frustrations not to be involved or be involved at the last minute on things which haven't worked. Few of you know me, others don't. So I just thought it'd be a slide about me. And I'm afraid even Tanya and James will know, took us ages to get the logo right for Yorker Connected. When we started the program, we called it the Central Care Record. No, seriously, the worst thing we could do. The patients hated it. They thought it was going to be care.data or something like the government was going to own, and they all rebelled against it. So we then made a really conscious decision to call it something else. We asked the patients to give us a name, and the name Yorker Connected, which is the very first element of the shared care record, was brought about by the patients and the patient rep on our group. Vic, who used to come to all our meetings and regularly, he got a group of patients together and they named it. And I'll be honest with you, that was probably the traction we needed to get things moving and to bring us all together. Nationally, I used to look after Patient Online, the program that preceded the NHS app. So the whole thing about patients being ability to book appointments into practices, order their prescriptions, and view their records ahead of the NHS app. That started in 2013, so I was the clinical lead on that and then the director for that. And I have done over time various things. I've negotiated the BMA, RCGP and other people, been reported to the ICO a few times and survived each time round. Had lots of fun discussions with CQC. In fact, we employed CQC staff during COVID when I was National Director for Digital Primary Care because they had nothing else to do. They weren't doing enough inspections, so they were bored. So we got them in to try and learn how to support practices with digital transformation, which is interesting. And I've been fortunate enough that each organisation I've been part of has invested in some of my leadership qualifications. So I have done some leadership work, and it's taught me quite a lot about not straightforward. And my first master's in medical leadership, my dissertation was on clinical engagement. And one of the things I learned was sometimes trying to bring people to your meetings is a difficult bit. You have to go to them. So find out where they're all meeting and go and gate crash with biscuits. And normally you're made fairly welcome and you can get things done. So there was something in that I learned many, many years ago in 2008, which has generally held true for a long time. And I have been both a CCIO, but I've also been a director with a budget, and I used to manage a £600 million budget for GPIT across the country for several years, which taught me a lot about what you can do if you're responsible for the money, but you need to be at the table where people are responsible for the money. So just a bit of background, and so but you can't do anything on your own. All of these things have taught me you've got to have colleagues on board and bring people together. I put this slide in just as a reminder. This is a slide, I think, post-COVID. Things changed for all of us. Things may have been going well pre-COVID, and we were on a trajectory. COVID hit, things changed. A lot of things happened quickly. Some of the frustrations we had about digital transformation suddenly happened overnight. Okay, some of those changes sustained, and then suddenly everything seems to switch off again. People will revert it back to, well, actually, we don't need to do this anymore. COVID's over, pandemic's over, and it seems to be that the NHS is under more pressure. I don't, in my time, I don't think I've seen it under as much pressure as I've seen it now, where people, there's a whole thing about patient expectations, and I seem to hear this from all sectors. Patients normally, were vocal against our non-clinical staff, but they're vocal against clinical staff, and it's almost like a demand. I demand this now type scenario, and they may not need it, but there's a whole thing, and that has started to have implications for a lot of our clinical teams and people leaving the profession in some cases. So shortage of clinical staff, burnout, all these things we've got to do that are in our contracts. I think giving us a lot to think about. And I do think it means that we can't just carry on doing what we've always done. So we've got to do things differently. So, part of the work I'm doing in outpatients, diagnostics, and in digital and shared care is all about, it's time for us to think about our model and think we can't sustain this anymore. We've got to do things differently. What's the different model? We've got to start, and I put this question on there, do we think we're doing the best, working together in the best interest of our patients? And I think if I use that as a question when I go to some meetings, and some of the meetings Tanya, James, John and I are at regularly, I think that's missing. Yeah, and we don't always feel like, it doesn't feel like the people in the system are there and get the fact that we're all got patients to look after. And if we asked our patients if they felt we were working together, they'd probably have various views on that as well, and based on their experience. And I do think we do need to think about, and then when we want to do things, we've got CEOs, CFOs, delivery officers, strategy officers, all these people to convince to get things done. And so that is a challenge. So I do think we need to try and have a narrative that works, that people can sign up to. And that, I think, the designing processes through the eyes of the patients, making patient care safe is probably the strongest narrative I can think of for anything we're doing. Normally people can't argue with that. This slide is 10, 12 years old. Okay. Even before integrated care systems came along. And we were trying to do this. We were aiming to get people in front of the right person in the right place the first time around, the right care. Okay, we've been trying to do that, and we've had lots of things. And I put this together at the time because I felt like shared care records would be a critical part of this. But there are certain moving parts of the system. How do you bring all these parties together? And this is the whole thing. But if you do truly achieve coordinated care, there's so much to, so many rewards, so many benefits to patients, so many benefits for us. Okay, and so I put this as a reminder. This is something we're still striving for, and something we should try and at least have a vision and sign up to together, because it will make, if you think about the patients getting better care, access to care where they live, seeing the right person the first time round, okay, it will make us think about all the things we're involved in. Even the management of chronic conditions. Tanya knows if renal patients are managed in a particular way, better control, seeing the right person knows what they're doing, they will hardly be seen in an emergency department, in general practice or somewhere else at all. See the wrong people, and they'll be bouncing around the system all the time. They'll be contacting out of hours, they'll be contacting their GP, there'll be an A&D. So all of these things do make a difference. Number of outpatient visits. So just as a placeholder, this is, again, it makes me think of why is this a 12-year-old slide still something we're striving to try and achieve. So Birmingham and Solihull, 185 practices. Okay. Has which is that 35. So I've put the courtesy of David Rogers, who was the clinical program lead at Royal Orthopaedic. I don't want to take credit for somebody who's done a lovely slide. So it was 185 practices, 35 primary care networks, 6 localities now, all our community care trusts, our secondary care hospitals, the local authorities, as well as all the different people. Now you've got to get them to work together. That's our biggest challenge. Is all of them want to do the right thing, but they're all off doing their own things. So this slide is all about how complex Birmingham and Solihull can be. Equally, when I was asked to look at clinical referrals and pathways, I realised actually it's like a Jenga block. Okay, there's so many things that have happened over time that unraveling it, there's a risk of breaking things. So you've got to be really careful. But also with a focus on going forward, we don't want to build another tower of Jenga blocks. Okay, we want to build something sustainable, and there are ways to do that. So which means strong foundations. Okay, so whatever we do now must be with the thought that actually it might be the most basic things, but basic strong foundations will give us an opportunity to take this forward. So referral optimization and clinical pathways, why? Well, everybody here knows about the 7.5 million, 8 million patients who are on waiting lists, okay? And the increasing demand for appointments. And we're all being asked, every ICS is being asked to look at their waiting times for patients and bring them down. Not many were looking at the front end, they were looking at the back end, saying, can we bring down the people who are waiting a year and a half to down to 65 weeks, down to a year? Okay, what about the fact we're still referring in as many people as ever? Are we ever going to win? The fact is very clear from consultant colleagues and specialists that they were being asked the same question over and over again by many. Imagine the 184 practices asking the same question over and over again about the same thing. There must be something in that. So clearly there's something wrong if all those people don't know the answer to a fairly common thing. And data. So I'm going to bring the theme of data through in this presentation, because as much as anything else at all, there is some really important ways of trying to tackle this. And I do think we shouldn't deny the fact that data exists in our system, that it can help us focus on what things we should do as priorities. And the other bits are, like I said, I'm more than happy to share slides. The other bits are the reasons why, which, why, and how, but I won't prolong that. It also made it really clear to me that the rules need updating. Okay, so we've had rules from many organisations, all with 3-letter acronyms over the years. Okay, who've changed, and they've left some of their legacy processes, commissioning, intentions. So the whole thing about consultants can't refer to another consultant, or if you want to do, if you want to expedite an appointment, you need to go back to your GP. So and so can't do these tests. Okay, it's amazing the conversations I've had. And so we haven't got a clear set of updated rules and guidelines in our system. So definitely, it's obvious in Birmingham and Solihull. But there is a forum where the medical directors of all the organisations come together, and that includes primary care for me. I don't want to look like actually it's primary care needs to be part of that set of working to those rules. So and the rules just allow us to have a much fairer process, very transparent about how things should work. We can look at where things aren't efficient or working effectively. I do feel we spend quite a lot of time is spent haggling about who should look after the patient and who should do what, because we haven't got a clear set of rules. And I do think we need to try and sort this out going forward. I asked for a feedback from referrers, especially, and said, what can you do? Because I hear all the time about referrals being rejected or returned. Okay. Well, from the referrers, if there were better quality referrals coming in from the referrers with the right information in it, right attachments, relevant history, would make my life easy. So we'll talk about how that fits with the shared care record. Well, aren't they obvious that nice guidance already tells us that you could do this? Why are they not following nice guidance? Well, nice guidance may not be as straightforward as you think it is. Why has the referral gone to the wrong place? Why can't they send it to the right place in the first time round? Yeah. And also the number of processes to request advice. Specialists, why don't they know what medications the patient's on? And why do I have to keep sending them the list of medications, the list of blood tests? Why aren't they using the shared care record? Yeah. And could they all? And why are the specialists in the same department sending me different responses? Okay, for the same thing. Isn't there standardized? In fact, some of them are really grumpy, and others are very nice. How does it work? Why can't they all be nice? And the clinical pathways, the coding of the outcomes, even looking at data, the data shows you it wasn't really easy to work out the outcomes for patients seen by specialists because the coding of the outcome wasn't being done in a standardized way. And equally, as commissioners, the ICB is getting all this stuff. And actually, what can we do to help facilitate this between referrers and specialists? And I've taken away from this. The headings used to be primary care, GPs, and specialists and consultants. And for the first 6 months of my job in the ICB, all I got asked was by lots of consultants saying, I'd love to do webinars with GPs and tell them about my specialty and how they could do things. And I'm sitting there thinking, are you sure this is going to work? And they may join the webinar, but there's a good chance that the people who are enthusiastic will join the webinar, but the people you really need to reach won't even attend. How are you going to get the message to them? Okay. And so and the referrers now has changed. I've had conversations all morning about, well, who are these people called physicians associates in general practice who seem to refer, and what training have they had to do a referral? okay, and various things. I have trainees, I have new salary doctors, all sorts of people in the mix who are doing well. So, and I can't tell who's referring and what training they've had. What's the process? So there's a question about how can we put some rules into place about how things should be done. So the next few slides, data. Just want to quickly give you a bit about how to be objective. There's lots of data in the system. So the providers will have their own data on their own organization, but the ICBs and ICSs have data about how different interactions work. So I just want to try and show you just a quick canter through about this, about trying to focus in on which problems to tackle and in which order. Because everybody thinks, normally you get the person who's the loudest, most enthusiastic, comes forward, wants to do it, and then you realize, oh, that's great, but there's no quick wins to be made from this. So first slide is on advice and guidance referrals. Well, now we can split it down to localities and PCNs. So we have a really good data analytics team who will hopefully be able to break this down. So I can now look at my locality, central locality, my PCN, and I can see that actually we do a huge number of advice and guidance requests to GI, to dermatology, okay, and neurology. So there's already, so interesting. But then I can look at another locality, which is just down the road, which is Solihull, which has a more elderly population, and their focus is orthopedics and cardiology. But it just shows you. So if I was working with them, I was working in my locality, which sends a lot of patients into QE, and then I've got one down the road where they send a lot of patients into Heartlands and Solihull. I've clearly got some data which shows there's some specialties I could work with on pathways, which would make a difference into the referral activity. But that's just some really simple data. Okay, so it just shows, so rather than going up and doing something really rare on allergies, possibly, or infectious diseases, which would be great, and we should do it. I can see the focus of the areas I should do some work on, where I would get consultants and probably local GPs and referrers to collaborate. Tanya, I'll send this round so you don't have to twist your heads and neck so much. Sorry. It is interesting when you start looking at this. This is the problem. You're going to end up spending ages looking at data because it gives you this. Equally, I'm giving you this to a locality. We took the analysis of a locality data, and I've taken away the names of each of the PCNs just to so this is a locality in one area. There's 6 primary care networks in this locality, and if you look at the data, you can see, there are certain PCNs or certain practices doing huge amounts of referrals in some areas. Now, if you look at the data, it tells you top areas: GI and liver, neurology, child adolescent services, and dermatology. Okay, and then within that, if you speak to the specialists, they'll tell you the most common questions they keep being asked over and over again. So why don't we do something in this space and get some pathway work done and publish guidelines agreed, which makes sense in this area. So again, the data shows you the areas to focus on that you can do something with. The next slide, because we talked about referrers, is, well, what happens with the referrals when they get to the hospital? So we've now got data on what happens in terms of the number of requests coming to different specialties, how long it takes those specialties to respond, which is really important. Okay, and in many cases, what's really important is, again, learning how to interpret the data. If the referral gets turned around really quickly, and then on the whole, it doesn't get referred back into the system, it tells you there's a good chance that the referral may not have need to be made in the first place. Okay. Equally, the data shows if in some specialties they're sending referrals back, but the person gets re-referred within a few days, it tells you maybe the advice could have been different or of a different quality. So there is plenty of data in here which tells us about which specialties are getting the most requests, what sort of referrals they're getting, and then where the specialties may be struggling to respond because they haven't got the resources. I don't want this to be about, there are some specialties where they clearly haven't got enough consultants or they haven't got enough protected time to really respond, and therefore they're struggling to do turnaround in this. Whereas others, renal being one, the most common questions about, well, if the one response back and there's no re-referral, tells you that actually that maybe with some guidelines we could have done something differently. And did the referral need to be made in the first place? Could the person have had an ultrasound scan, and if the ultrasound scan was normal, not being referred in the first place at all? So the data does tell us quite a lot. So this is readily available to us. So what can you do once you identify this and you've got the data? Well, gastroenterology came to me and said, "Oh, we're getting huge amounts of referrals. We keep being on the hit list regularly for, how could you do things better?" Some of the referrals we get, clearly people haven't looked at some basic guidelines, and they showed me some lovely flow charts that they'd been designing. Some of them I couldn't get my head around. So I looked at these flowcharts and thought, they're lovely as they are, they keep going around in circles. They don't make sense to me. And there is a bit about sense checking these things. And so you've got to, what may make sense, complete sense to a specialist, makes no sense to anybody else at all, or limited sense, and they can't interpret it. So the first thing was, look, it's great you've got this. It's really good. We want to do something with this, but can we simplify this? Okay. Now, once you've simplified these, we want to share these. This is the next step. So across all 185 practices in Birmingham and Solihull, on their desktops of every member of their team, we have put this one icon called BSOL ICB Clinical Pathways. If they click on that icon, they will end up on a landing page called Clinical Pathways. Yeah, and that Clinical Pathways page now has some really clear icons on it. And I'm happy to put the link in a second when I get a chance in the chat. And we've started to identify specialties you can go live. So gastroenterology. If you click on the gastroenterology box, it will take you to a set of pathways which have been agreed. We've had celiac pathway signed up today. Irritable bowel, inflammatory bowel disease, and you can click on it. And if you click on irritable bowel syndrome, the most common reason that people get referrals is a raised fecal calprotectin level. What to do with it? Now, in this flow chart, it's really easy. It tells you less than 100 do this, more than 100 do this, and it tells you that all the steps, the things you can do, and it's a much simpler flow chart. A lot of the we've got a really good member of the team at UHB who's been very good at flow charts, who's helped us design this. Hematology, get lots and lots of requests for slightly elevated ferritins, slightly raised platelets or anything else at all. Okay, and what the hematologists were doing is every single time they got that request with advice and guidance, they were attaching the guidelines back, and hopefully in some cases the GPs would get it. In some cases they remember to look at it next time around. In many cases they weren't. So what we did was publish the guidelines and make it really easy for the hematology guidelines to be available at one click, hematology button. You've got the guidelines available to you. Renal have done the same for us. The local medicines formulary is also on here as well. Okay, and so all the drugs you can be prescribed in primary care are on here. The ones where the specialist needs to initiate it is on here as well. So it's one page, one icon, people can get to it. We've also put a feedback button. So we've created an email account which is hosted by the ICS, which is just called nhsbsolICB.clinicalpathways@nhs.net. So constructive feedback about the pathways. They make sense, they don't make sense. There's delays in responses. Feedback is being collated on a regular basis there, and we can then update the pathways and change them if we need to change them. Okay, so we've done that. It sounds like nothing special, but the fact that actually this is easily available, and we now have data from the fact that these pathways are being regularly used. We are going to do more. This is just a start at the moment. We're engaging with each specialty across each trust and saying put them forward. I now have medical directors all signed up from each provider, and I've asked them to nominate this. So all orthopedic are going to start with osteoarthritis, greater trochanteric pain syndrome, and last one, young adult hips, because young adult hips never seem to make it to them in the right way. John, who's on here, is going to give us the pathway for TMJ dysfunction, because that seems to go wrong, doesn't it, John? With BCH, it ends up in all sorts of places. Okay. Both women's and children's, huge long waiting times for pediatric gynecology, pediatric ENT. So we've got those pathways being sorted out, so we can make it really easy to make those referrals. So the most important thing was the collaboration. We now have people interested. They've realized that they can do a webinar, but they need the resource to be available easily. The hope is that this is not just going to be for primary care. That I know discussions are going on with Tanya and James and others and John, whether this icon could be easily available to anybody in those teams, so they could easily look at these pathways. An ED junior or consultant could look at this and go, "Oh, this is what happens for renal. Before I refer somebody with a slightly decreased GFR, I can follow this pathway and see what to do," because it makes complete sense for a referrer to use the same pathway no matter where they're coming from, out of hours, emergency department, community, wherever it is. There is an agreement for us to try and do that. The other thing we've been trying to do is something on patient engagement. It's really difficult for patients to know what happens when they get referred, and we're doing a system-wide access policy, but getting an agreement for how we treat our patients in terms of outpatient path journey. So, and so the agreement is that the ICS will host the information. Each provider has its own information, but it will be consistent. What happens when you get referred? Okay, how long do you wait? All the other commonly asked questions. So we can promote this. Average waiting times are tricky. Average waiting times on the planned care website are based on a combination of 2-week waits and the normal. So when you look at it, it might say 13 weeks, but it might not be realistic. So we are trying to work out on a better way of saying how can we tell our patients they will have to wait. UHB has gone live with this, but this one of the most common requests I got was patients get referred and then they ring the GP surgery trying to find out if the referral's been done. Then they're ringing the hospital to find out if the referral's been done. So quite a lot of phone calls are happening. So as of the 1st of May, we've gone live with a system within Birmingham Solihull where patients, starting with UHB with other providers, as soon as the referral is received from the practice, from an referrer to UHB, goes on the system, a text message or an email goes to the patient saying your referral has been received. And along with it, it starts to tell them about the journey. We now need to put behind that a bit more about what happens next. But the starting point is this starts to reduce the number of queries coming in. The patient now knows the referral's been made. It does mean that all of us have got to get better at making sure referrals are done in a timely manner. But equally, it'll stop the whole issue where referrals get missed. So maybe somebody's gone to see their GP or somebody else. They said they will do a referral. If it becomes normal to receive a text message saying your referral's been received, and you don't get that text message, it's almost a nudge to say, do you want to check in what's happening? Hopefully, because all the queries we got where the referrals have been sent will disappear because that's happened in the text message. We'll be able to focus on the ones where the referrals haven't been made because we are human beings, things get forgotten. The trickiest bit of the patient communication I've got to manage is asking patients how to be patient about there are waiting times. You can't change things. If nothing changes clinically and it's routine, there are some specialties where you'll wait at least 6 months to be seen. There's nothing we can do about that. That's the resources in the system. So we've got to find a way of finding out to manage that. At the moment, there almost seems to be a thing where patients see somebody, get referred, and within 2 days they phoned up the hospital to find out how long it's going to be. Heard it's 6 months, and they say, "Oh, but I want to be seen earlier." And the message is, "Well, you can ask the referrer to expedite your appointment." Nothing has changed clinically. So why would anybody do that? So we are working on a very clear expedite policy. So far, the policy in the system has been to go and get the GP to write another expedite letter, which changes nothing if nothing has changed clinically. So we do need to manage the message. So again, in the next couple of months, we're going to have a very clear messaging to our patients saying, unless anything changes clinically, your appointment will be 6 months, which some people won't be happy about. But if all of us agree that, that'll work. Just got a few more things, Tanya, and then I want to take questions. Other things, and this is just to give you a sense of other things that are happening in Birmingham and Solihull. And this is generally, I want to tell you about apps. Okay, we've moved from a world where people had to wait to see somebody to be given advice about what to do, and when I got involved in the MSK clinical pathways transformation piece of work, they told me about something they'd procured at the Royal Orthopaedic Hospital. And what this solution had been procured for was of all the patients on the waiting list to be seen by physio at ROH were now being sent a link to an app where they could download this app and start to look at some of the exercises that they would be given when they eventually got to their physio appointment. Okay, so and some people were starting to use this, and as a result, not needing their physio appointment and were cancelling their appointments. And that's a good win. Well, what can we do? Why can't these patients have access to this even before they get referred? Because these people have been referred into the system. So now across Birmingham and Solihull, we have, and this is available to all the patients of Birmingham and Solihull, the 1.3 million patients, is that at any point, either based on their practice they're at eventually with the pharmacies, we're going to be doing it in the ED departments at UHB as well, and others. If a patient ends up with musculoskeletal pain, they may need to still see somebody, and the appointment might be a week away, but they can be prescribed or signposted to the app, and the app will start to mean that they can have exercises straight away. If they come to my practice and they wake up one morning with back pain, and they go into our website, they can download the app from the website. Okay, and the app, starting with just the video plays. Yeah, the app like this has many different conditions on it, and they can then choose the condition they've got. It almost also triages them to make sure there's no red flag signs, nothing worrying symptoms on there at all, how long things have been going on. If there's anything to worry about, it locks them out of the app and tells them to seek help from a clinician. Equally, in many cases, there's nothing to worry about. They can fill it in and it will give them exercises appropriate to their condition. It also tells them about how to optimize what medication they're on, how to take paracetamol, when to take it, when not to take it, what other medications they can take. All of this is done in a very standardized way and it's available on here. So we've rolled this out across Birmingham and Solihull. We're getting people to use it more and more, and hopefully this is the start of apps being available. Why are patients having to wait weeks to see somebody to be given advice on something that they could have had on day one when they wake up with it? So things that I know women's and children's are looking at it for menopause. There are other conditions where this could easily be done. So we are looking at other ways that we could make apps and information available to the patient on day one at the time when they need it, not weeks and weeks later. So I'm just going to just go, and again, data. I come back to the whole data thing. The data is being used to try and encourage people who aren't using it. So, again, this is the data of all the primary care networks and practices across Birmingham and Solihull. I use this when I engage with the practice and say, your practice is using it. Why aren't others using it? Why are you missing out? And same with providers. Providers are using it. You see that actually the back pain pathway is the most commonly used one, knee pain next. All age groups of patients are downloading it and using it. So data tells us actually it's worthwhile. We shouldn't be saying that this is only available to certain patients. So again, very useful data on this. Diagnostics. When I started about a year and a half ago, there was a whole battle going on about direct access for diagnostics, and most at the time referrers and GPs in this case, if you wanted access to some diagnostics, including a renal ultrasound scan, you had to put in an advice and guidance request to radiology, and then they would look at it and authorize it. So the first thing we did was get agreement about pathways. So the first 6 months, 9 months of my job was to agree some pathways, which include renal, which is which are the clear criteria where a GP or somebody from the practice can directly request a renal ultrasound scan, or request an urgent chest X-ray. We had about 5 or 6 pathways we had to develop. We got them done. And then thankfully we were able to roll out something called the ICE radiology system. Many of you will have this, okay, and it's used in many forms. And I know in various parts of the West Midlands they use ICE radiology along with iRefer and various aspects of it. The most important thing is we should spend almost a year agreeing pathways. We then populated this system with those pathways. So if you wanted to ask for an urgent chest X-ray, you had to tick the next box that would appear would be saying to click the reason why you want an urgent chest X-ray, and it would make you think. Okay, and then you have to tick one of those boxes, and then it would make you fill out the form appropriately. But it meant that at the point in time you could do it. This also meant that clinicians were now thinking about it. Rather than sending some information to an admin team to merge a form, print it, and sign it, and scan it and email it, they could do it while the patient's in front of them, and a clinician would complete the paperwork. So 72% of the practices in Birmingham and Solihull now are active and live using this. A few others need licenses and things, but it now means that we've got a standardized way of doing this. The radiology were nervous about this whole process, about being overwhelmed with requests. I regularly meet with them. The data shows that they've not been overwhelmed. The number of returned referrals is minimal, okay, and the number of more appropriate requests has gone up. So generally the system works, and it's just worth thinking about how you use something as simple as this to nudge and encourage people. ICE in its basic form still has other bits that you can use with agreement to help people choose the right investigation the first time around. And I think that's what it's all about. And so diagnostic transformation, we've got community diagnostic centres, we've got all sorts of places that we can send people to. Phlebotomy hubs we're looking at as well. I do think, people say, well, actually, what's my role in all of this? Well, all the CCIOs on here and the CCIO network, you need to be part of these conversations. If you want to get the most out of community diagnostic hubs, if you want phlebotomy hubs and phlebotomy services to work, they need to understand what can be done. Access to shared care record, why order comms should be central in a particular way. How the pathways into a community diagnostic centre should be no different to those into a hospital. Okay, everything should be the same. How results back from imaging, ECG, spirometry should go back to the person who requested it. If you and I aren't part of those conversations and at that table discussing this, okay, what will happen is these services will be designed based on how things work now, not how they could work in the future. So, Tanya, if you're requesting a test, why can't it go back into to the person who requested it? Because they know most about them. Whereas actually people are designing, it goes back into, well, I'll get so-and-so to request it, and they've got to forward me the result. I still get requests saying, can you order this test, get the result, and email it to me? Well, that shouldn't happen. And unless we're at those conversations about diagnostic transformation, that will continue to happen. Okay, because people don't realize there's a more efficient way of doing it, and they could do that, and that service could be designed in a more modern, more efficient way. Shared care record, James, Tanya, and others are much closer. This has evolved from what we do, the Yorker Connected. I spend most of my time calling out colleagues who aren't using it. Okay, so all the practices with the shared care record started with primary care making information available and providers using it, other hospitals using it. It now works both ways. Okay, why am I writing to Tanya going, what happened to somebody in your hospital's emergency department when I can see the letter? Okay, so I use this, the way I describe this, and the mandatory clinical session that's happening in my practice. Every clinician who's attending that will be shown how to use the shared care record portal. So there's no excuse, and they'll be given examples, and I put examples in here. So I have a patient sitting in front of me now, and the patient's saying, "Oh, I went into hospital. I had a test. Have you seen the result? Have they sent you the result back?" And what I'd normally have done in the old days would have said, "Oh, I haven't got it. Let me and I wouldn't remember the login to a portal that I might have been had a login to. And I would have said, let me send a request to my secretary, who will then email or try and find it. They'll then find it, send it back to me, and I'll let you know. Well, on a regular basis now, I log on. I just will press a button. I can see what's happened. I can see their outpatient appointments. I can see if they've had an X-ray. I can see if they've had bloods in A&E, what the diagnosis was. I can see their oral glucose tolerance tests in the outpatients from a maternity clinic. And I go, the result's normal. Thank you very much. Done in that one contact. That makes life easier it's better for the patient and it's better for me. Okay, I've got no additional tasks to worry about, no additional work to do. So the shared care record does this. And so all of us, it's all going to well having shared care records. The business benefits, all the benefits will not happen unless we start to promote it in this way. And so some people, colleagues out there, still don't realize that the simple icons, what these things like health share, the S on system one, what do they mean? This has been live for a while. And I think one of the frustrations that we have locally, and which is why each of the CCIOs in Birmingham and Solihull are championing this within their organizations, is making sure their colleagues are using this. So we're now trying to find ways to make sure that this is a no-brainer. There should be no longer a flux of letters saying, can you please do the PSA on this patient and send me back the result? Okay, or can I please have the results for this patient, because they should be readily available for you then and there. And again, data. I've taken this from our last set of reports from our organization that we've got data on every single practice, who's using it, who's not using it, to encourage people to say, well, actually, if you're not using it, it's almost certainly you're making your life harder. Really small, Tanya. I will send you a bigger version of this. This is a local data pack that Phil Downing shares at the primary care meeting. But again, we're doing well. We're increasing it, but this should be in the millions on a monthly basis, based on the number of interactions we have. And I think we were aiming to try and get to that. But I think each of the CCIOs are committed to, in Birmingham and Solihull, to making sure they lead on this and make sure people in their organisation know this exists, because this is what makes their life easy. And I'm going to stop at that point, because I think it's thank you again. Digital is important, but I think it needs to be part and parcel of every work stream, everything else we're doing. And I think people need to realize that actually it can't be just a work stream on its own, left to its own devices. Tanya, as an example, Tanya, you know that you've now been got involved in the urgent emergency care work stream with the person leading on urgent emergency care, and that as a result has meant for a more meaningful conversation. Okay, straight away Barbara came back and said, Masood, really good conversation with Tanya. She can work. I can do something in this space, and that's going to make a difference to urgent emergency care. And so I do think all of us have got a role, and we need to be at the table in these critical urgent emergency care, chronic disease management, elective care, cancer. All of us have got a role in that. And unfortunately, we shouldn't be waiting to be invited. We should be part and parcel of these teams.